Hi, I'm Rhonda Kelly with All Clear Foundation. Thank you for joining us for this session. I'm really excited to speak with Dr. Ron Schwenkler and Dr. Eric French of Mind Spa Denver about the use of psychedelics in therapy for trauma and stress-related injury and other breakthrough therapies that can really shift the way responders are experiencing their career and their lives. So I'll let the doctors introduce themselves. Would you please tell us a little bit about your background and what brought you to this work?
You bet. I've been in the mental health community. It will be 27 years next month. So I've got a master's in counseling, a master's in clinical psychology, and a doctorate in clinical psychology. I started out working with kids and families, and I just kind of fell into that. You know, it just came really natural. It wasn't really the plan, but I started out, and then working with those families, and I just realized that trauma. It seems like any family I worked with, any adolescent I worked with, trauma was just a part of the narrative at some level, and so it just made sense through my education to keep on specializing in trauma. Over the last, I think maybe 10 years, it's been my sole specialization. So through my doctorate, that's pretty much everything. Every class I took kind of focused on what new aspect of trauma can I learn about and work on. Currently, after I graduated, then I started focusing a lot on personal injury work. So a lot of car crash stuff, and that was probably the closest I've ever come to single event trauma. Usually that's kind of like a joke, because like who has one trauma, right, in this life? And so but I actually saw people that just had one trauma, and that's refreshing. It's really cool to be able to help people get back on the road, literally. But then through that experience in my private practice, I've been working with veterans, first responders, and then childhood trauma victims, and just anything that I can do to help those people. And it just kind of evolved into meeting these two, and it's just kind of taken off. It was synergy right from the get-go.
Fantastic.
Yeah.
Great. Eric?
Yeah, and I'm Dr. Eric French. You know me, we've met before. So I'm one of the co-founders and med director here at Mind Spa, and like Dr. Schwenkler, psychiatry was not even the plan. That was not my intention as I was going through medical school, and I was pediatric neurology with subspecialization in neurodevelopmental disorders all the way, and shift paths, near the end, and which was very frightening, but found engaging with my patients on a deeper level and not having to stare at diagnostics and lab work and computer, but to really connect with a human being was a lot closer to the ideal of practicing medicine and healing than I had initially envisioned. So, connecting with these guys, with Sam Peterson, he's our Director of Business Development, and Dr. Ron Schwenkler has really meant everything, because we have been able to dream forward our ideal of how healing takes place, and as opposed to just working for somebody else who is dictating what this care looks like. So it's been really exciting, and I do focus a lot on trauma myself because I have my own trauma history. So I've battled with depression and trauma as well as ADHD for a long time. And I know how important it is to connect with patients and be more than just, them be more than something I read about in a book, right? So in approaching my own history, I've been able to bridge a lot of gaps that way, and it's just been exciting work. And being a veteran myself, Sam and I are both veterans. Sam's a combat veteran. We feel that it is essential to be reaching the veteran active duty first responder community, because the work is intense. As you said, stress injuries, trauma, this stuff is very important work, and a lot of times it's the difference between high performance and low performance. And the people who are engaged in these career paths are looking for high performance. So it's we've been super lucky to kind of examine the outpatient mental health care model and challenge every aspect of it possible.
Fantastic. Well, and I noticed from the beginning that was one of the parallels between our organizations is that we really do focus on performance, doing well on the job, but also doing well in life and not suffering needlessly. And I think in the military cultures, the responder culture, the healthcare worker culture, there's been this glorification of martyrdom and putting others first, the expectation that you should just be able to perform and to endure everything. That quote from Rachel Naomi Remen I love is something about being expected to walk through trauma and suffering without being impacted is like being expected to walk through water without getting wet. And, and I see, so many similarities between the veteran and military population and responders in regards to personality, motivators, impacts.
Yeah, I think it's, we like the idea of looking at trauma from a performance point of view. I mean, professional sports do it all the time, right? And in baseball, it's called the yips, right? Where we have a flow state, we're taking care of business, we're doing our jobs, and then something happens and it interrupts the outcome that we're used to getting. What's that thing that interrupts it? It's it's a life event. It's an adverse experience. It's a trauma, and that could be a small T trauma, all caps trauma, big T trauma, right? I mean, there's lots of layers of trauma. But we want to get people back into their performance, right? We want to, in a sense, going off that quote, to help people learn how to suffer well so we can get the wisdom that comes from trauma that we normally wouldn't be able to get anywhere else. Like, we can read a lot of different stories and we can feel impacted by them. But until we go through it, and feel our way through it and transcend it, then we get at a type of wisdom that is reserved for those that have suffered.
I love that concept of suffer well. I hadn't heard that before. Well, what have you seen? What we've noticed over the past couple of years is that there's been a significant increase in the openness of responders to admit that they're suffering well or poorly, and to reach out and ask for help, to realize it's not shameful, to see some destigmatization, particularly around the mental and emotional suffering, and that there's been this anecdotally reported significant increase in responders using substances, whether it's ayahuasca or mushrooms or others, in recreational settings or in ritualistic settings. Microdosing, I've been hearing a lot about. What are your thoughts on that, especially versus using them in a therapeutic setting?
Yeah, I mean, it's interesting the remark about there being a little bit more of a generalized acceptance across the board. I will say yes and no to that simply because, and Sam will tell you this, as a combat vet, that if you verbalize that you need help for mental health, that can literally jeopardize your security clearance. And so, and I think that people do fear that it will impact their day-to-day job and this thing that they love and are committed to. But certainly, we do see more of a drive towards an acceptance as more specialized care is provided, right? Like being able to reach this demographic in particular, where they are at, is so essential to having that sort of conduit to a more healthy career, right? But to speak to microdosing of various substances, psychedelics, things like ketamine, psilocybin, MDMA, the literature has been there for a long time, right? When these things were falling out of the labs and into people's laps for recreation, in general, the whole concept of doing further research was sort of dropped like a hot potato. But we've had good data on this for a long, long time. And the fact that we're circling back around to that again with good effect is really exciting. But it is a very nuanced and specific way of approaching that needs to be done right. Like the recreational approach it lacks so much in the way of understanding these substances and how to prepare a patient for them, the coaching around it, the way to optimize that treatment to get that connection to the why is really, really important. And I think one of the reasons it is a little bit more appealing to the first responder and veteran demographic is for good reason. A lot of people don't want to be on a daily medication. There is a lot for want in the way that they are prescribed currently, in the limitations that they have. And I think the concept of doing something like this and having some deep, intensive work associated with that is a lot more attractive than being on a daily medication for most people.
Well, I think among this population in particular, there's this thought that, well, if I'm going to suffer, I want to get something out of it, whether it's growth or insight, which I guess is growth.
Yeah.
But the preparation, I know you're both very big on making sure there is appropriate preparation and appropriate follow-up to therapies.
Yeah, I think, what setup can be everything, and that can be a personal meeting. I mean, that's really what I think people are looking for, symptom reduction and a shift in meaning. I think a shift in meaning causes great symptom reduction. And a symptom reduction in and of itself does not necessarily cause a shift in meaning. We want to be able to relate differently to these traumatic memories, and how do we know we're relating differently? Intensity decreases, we're not experiencing them as much, right? Not for as long, right? So intensity, duration, and frequency are changing. And we're allowing that meaning to trickle through in whatever way that is, which is very personalized. But, we spend a lot of time with psychoeducation helping people prepare. Like, we want to stalk meaning. We want to get after it and not just be a passive, experience of, I hope this works for me, right? That was one of the things that will come back to me, but yeah.
No, and that's so important, right? Because there are a lot of places that will do this work, and I'm grateful that they exist. But I think there is an implication or a sort of an implied idea of let the medication do the heavy lifting, And in my opinion, feeling better is nice, right? But transformative is so much better.
Right.
And there's an opportunity with a lot of these substances that we can apply. And that's why I feel like it's so important to have this deep understanding behind it, that we can really wring that treatment out for every drop that it's worth, instead of just saying, sit down, feel better. Like there's ways that we can connect to this in a different approach that takes our patients a lot further down the road in ways that do create meaningful change.
Right.
Well, and I'm sorry to interrupt, but I like what you had said, well, both of you have said it, that a lot of the traditional medications, the prescription courses, are more about numbing or reducing the symptoms without creating healing or transformation. And I love that term. And I think that the way you provide the set and the setting is really having an impact on the outcome for your patients. Do you have any thoughts about that, or can share why you do things the way you do them?
I think that speaks to the concept that we've coined in regards to experiential psychiatry, which has to do with layered interventions to approach the sophistication that the patient has experienced in regards to trauma, right? Like, trauma doesn't happen in one context, right? Like, we take that thing across several contexts, and we experience it on many sensory input levels, right? And so our idea is to invoke different interventions, traditional psychiatry, traditional counseling, with sensory inputs that are allowing our layers, we could say it, we want our resources and how we approach the intervention to be layered so we can speak to the multi-contextual experience of trauma that they are experiencing.
Love that. Well, and we've spoken before. I know some of the shortcomings I've heard from a lot of responders with therapies like EMDR. Some people, it seems to work very well for. Others say, I could never get to a safe place. When I was being resourced at the beginning, I just couldn't calm down. I couldn't relax. I couldn't go back into whatever I was exploring because I didn't feel safe. I think that's one of the things you guys have done incredibly well, is create that external and internal sense of safety.
Yeah,
absolutely.
Well, we really want to invoke the biological experience of safety, which is very different than the cognitive experience of safety, right? So that's a big part. We want parasympathetic activation as much as possible through a variety of interventions so that they then can feel that experience somatically, which allows them to approach the trauma memory in a more secure way. But there's a really big difference between trauma interventions like EMDR and specializing in trauma theory. And I think that's where a lot of practitioners kind of struggle a little bit. Taking a certification course does not mean a person is schooled in trauma theory. That's a different effort, right?
Okay.
And so I think that's why I think a lot of people struggle with those interventions, because the person's doing everything right. They're doing everything that they were taught, except they don't understand the context of the theory, which allows that person to, either, worst case scenario, abreact, or, on a lesser level, just not get anything out of it. And then they have a tainted view of therapy because
Right.
it didn't work.
Exactly.
Right,
When we see that so often, when responders or military go to a counselor that they weren't able to establish a rapport with, they come back and what they tell people if they talk is, I tried counseling and it didn't work for me. It wasn't that I connected with a counselor that wasn't a good fit for me.
Yeah.
Just generalized rejection.
Yeah, and that makes a lot of sense. I mean, who wants to keep thinking about something bad?
Right.
And if we want to transcend trauma, we got to keep fighting for it, right?
Yeah.
Like when we go to the gym, we don't just work out once and go, that didn't work.
Exactly.
Right? We don't go on a diet and try a salad once and go, well, that didn't work. Like we gotta work at it.
Yep.
And it's hard doing that when biologically we're wired to avoid the bad thing, right? Like we could approach salads over and over again. I can't, but a lot of people can. But it's really, we're wired to just retreat from that adverse experience. And yeah, I mean, it's hard when someone has that adverse experience about therapy in and of itself.
Yeah, I think that some of that is on the responsibility of the provider to have a conversation, a very clear conversation with a patient who is pursuing some help, that, essentially it is not the tools that you're using to get better, right? It is the behavioral activation that you are engaging in or not engaging in once you are feeling better.
Great.
To do things differently in your life that is either going to fortify the distance from the symptoms that you've created or, undermine its structure entirely. And I think that, this is shame on us as providers for not doing a better job explaining to patients what these interventions do, right? I tell my patients all the time, talk therapy, medications, even ketamine infusion, transcranial magnetic stimulation, they're all tools. Right? Some of those are power tools,
Right.
but ultimately they are tools that are meant to create that distance from the patient and the heaviness of the symptoms that are concerning them, right? But then once that space is created and it's a little easier to activate and do things differently, examine your life like, okay, cool, my way wasn't working, right? How do I avoid this from falling back on me again? Like that's the work that is so important, right? So these are just vehicles, they're spotters, right? I tell my patients, if you're in the gym and you're on the bench and you're putting up your max and you're having a hard time and you're shaking and it's coming down, it's going to crush you, right? Like the spotter, these interventions will help you re-rack the weight. Right?
I like that.
But your spotter doesn't make you strong. Your workout makes you strong. Right? So we really have to stage and explain the process to our patients in a way that's meaningful for them to connect with, that like, oh, I got some work to do.
Yeah.
Right? And to make that a good thing.
And then that creates a balance to the why, right? Because then we get a lot more what, right? There's some space in there. The interventions are allowing some space to when history or the moment bumps into them, and then they can get into behaviors and do things a little different. One of the things that we say here is confidence comes as a consequence, and so we want to do things different. We have to engage in behaviors different, and that builds our confidence, and we start reclaiming ourselves after trauma when we can do things like that.
That's great. Can you talk a little bit more about behavioral activation, what that looks like, what it really means, and
How much time we got?
I love it. As much as you want.
I love it.
Yeah, I mean, there's a kind of an ongoing debate in psychotherapy. Does reason heal or behavior heal, right? And I think I'm would classify myself as a functional behaviorist, and so we really want to get into, especially in our emphasis with performance, we want to get into the right behaviors that allow a person to, like I said, reclaim their confidence, and And that has to be almost a mindful, a purposeful, not almost, it has to be
Absolutely.
a mindful and a purposeful endeavor. We have to go out of our way, especially using these moments after interventions, to really consider, what can I do different, right? Feelings are going to come and go. Feelings are fickle, right? I mean, they really are, there's just this impermanent nature to the feelings. We want to help people commit to the values and the behaviors that they want to optimize their performance, which then brings more meaning to their life, right? Because they start experiencing a self-mastery, right? But we have to develop that behavioral activation plan and help people go back to it often. And a lot of times that behavioral activation is, what can I do different? But also, what are the values that are driving that behavior? Right? How do I increase mindfulness to understand the context, then so I can pick the values and behavior that's good for that context. Right? So this is a combination of those things.
And I think too as we're discussing some of the application of psychedelics in a form of therapy, there is a distinct advantage on the other side of these treatments where there's more psychological flexibility that's created, right?
Okay.
So part of what these things accomplish is they significantly increase the brain's ability to talk with itself. And with an increase in things like brain-derived neurotrophic factor supporting new neural networks, we try to get our patients, and once again, this is part of the importance of the work around this. Let's capitalize, right? You've just had this treatment, you've got some flexibility, let's talk about how things can be done differently. You just had an experience that showed you that life can look a little bit different than you've been experiencing, right? How do we capture this and get you doing things differently? And I think that psychological flexibility is one of the most advantageous outcomes of these forms of treatment.
Yeah, brother.
In that psychological flexibility, does that offer a different perspective then, so it pulls somebody out of the ruts that they've fallen into?
Yeah, I like using the term of being able to turn over the Rubik's Cube and kind of play with it, right? So there's this, when we are using our own thought process to try to logic our way through stress, we keep thinking in the same path, right? And it's traversing that forward and backward, day in and day out, multiple times a day. But when you have the ability to really turn the Rubik's Cube over and to sort of, examine what is happening from alternative perspectives, you can have a new relationship with that event, right? And disconnect from the physiologic jarring of a trauma and allow it to become an advisor that strengthens you.
Yep.
That really reminds me of the quote, I think it's Einstein, that we can't solve our problems with the same thinking we used to create them.
Exactly.
That's right.
So true.
That's the problem with history, right? I mean, we rely on it so heavily. I mean, it's such a fundamental part of our lives, but sometimes there's answers back there, but we really have to focus more on what's the new thing I can do.
Right.
The old thing got me here, right? But there's also a fear of focusing on that new thing, right? Because we don't know what's going to happen next. At least the history, we know what's going to happen next.
Right.
And even if it's bad, it provides some safety because it's predictable, and predictability allows us to feel safe.
Yep.
But it's treacherous. And that's, this is, we talk about the mind using 5 descriptors. The mind is brilliant, beautiful, treacherous, silly, and stupid. And it's, our history can activate a lot of different parts of that. The current context activates all of that. And our mind can do all of those things in 2 seconds. How do we get that presence to witness it, to witness our history, to capitalize on the intervention so we can try something different?
Wow.
So we can practice more of that brilliance and beauty while being able to witness and catch the treachery, silly, and stupidness.
Wow.
Absolutely.
I love that.
Yeah.
Well, you had mentioned that there is a significant amount of research out there. Can you speak a little bit to the efficacy for various conditions, whether it's depression, anxiety, substance misuse, trauma? And what I'm hearing more and more from responders is just debilitating grief. I can't take another loss.
Yeah.
How does ketamine engage with those in therapy? Are there other therapies that are breakthrough therapies that you think are more efficacious? Does it depend?
Yeah, I think it depends on a lot of things. I mean, if we've done nothing so far, we've talked about how important it is to set the stage, do the groundwork, control the setting, and use this as opposed to just experience this, right? Like, so, the ketamine research is going to tell you that it helps roughly 80% of patients with significant depressive symptoms. But I have seen it utilized and applied in a lot of different ways successfully, right? So it's not just for depression. It's not just for suicidal thinking. If we are doing the right kind of groundwork around this, it can be used to significantly help with substance use disorders, to help with grieving a loss, reconciliation of anything that's terrible in somebody's life. It just really depends on the work that you do around it, right? This is a tool. So we watch these things applied in so many different settings in a way that is just missing the boat completely. So I think it is the importance of really using these things in a way that's meaningful for the patient and creating a difference in the way that they view their circumstances is in the construct, is in the way that we put all of this together.
Well, and you've talked a lot about setting the patient up correctly. You also, Ron, I know, talk a lot about the follow-up, not only the behavioral activation, but can you speak a little bit more about what that looks like in a therapeutic setting?
Yeah, I mean, it's the continued effort that we need to encourage people to engage with, right? I mean, change is, maybe we could say, our biological and God-given right? Like we are the animal on the planet that does change, and it's the hardest thing that we, have to accomplish. And it takes that aftercare, it takes that follow-up, a calling, sometimes randomly reaching out and just saying, hey, how are you doing with that? What are you doing about the intervention that you can feel good about that follow-up? But we really, this is Zen saying, it's like water dripping on a rock, right? Like drip by drip, you can't tell what's happening to that rock, but over time the rock changes drip by drip. And so we want to keep that effort, cooking in contact. And we're mammals. So like contact is really good. The right contact is really good.
Okay. Not all hugs are good. Yeah.
So it's like be a good mammal. I mean, that's one of our things. And it's, we can role model that as practitioners. Sometimes we get held accountable for it because maybe we didn't do it, and then we can correct ourselves and say, we can practice being a good mammal and say, I'm sorry, I'll do better. And we want those corrective experiences, but really we want to encourage people to take that bull by the horn and get it done. Try new things.
Yeah, there's other aspects of the aftercare that we like to connect with, our patients and the people supporting them through this, so that they know how to support their loved one who's going through this treatment, right? And to not get in the car after treatment and have an argument or try to, solve some very challenging problems, right? But to kind of foster and hold that space for their loved one who has just gone through this treatment to really capitalize on its effects in that moment. And as we're working on this behavioral activation and teaching them ways to carry forward what they've just experienced, we want the people supporting them to understand how to help them with that.
Right.
It brings them deeper into this person's care and process as well, which is, always an added benefit.
I'm sure it helps them feel not threatened by the change.
Yeah, that's a big deal. Right, so there's a psychodynamic idea or concept. It's called positive affect intolerance. And it's a significant part of trauma. It could be a significant part of having neurotic parents in general, let alone traumatic parents. But, we really are so good at adapting, and we really get scared of feeling good, right? Because feeling good means my guard is down. That means a random event can happen. That means I get hurt again.
Can be disappointed.
Right? Caught off guard, literally hurt, right? So we want to... We don't want to. We develop an intolerance to positive affect, and on to your point, right? The moments after treatment, it's just let's allow ourselves to feel okay, and notice nothing bad is happening, right? And then let's allow ourselves to get a little more used to that, and then do some new things, and then reinforce those good things with partners and and whoever else wants to get involved. And it's like we have to retrain the nervous system that like being okay is actually okay.
Right.
That's interesting. Several years ago, we did a workshop on stress injury, and we borrowed the stress injury continuum, so green, yellow, orange, red, and asked the group of responders, what does green look like for a cop? And immediately a cop stood up and he said, yellow is green. You can't go to green.
Makes perfect sense.
You're going to be victimized, you're going to be vulnerable. And just how deeply ingrained that messaging is I have to be on guard all the time because the world's a dangerous place.
Makes so much sense, doesn't it?
Yeah. How effective is the use of ketamine in resetting the nervous system?
It's very good for that. I think that when you have an opportunity to gain some deeper perspective on the circumstances that you are dealing with, we are able to reset. We come back at things with a different, a different narrative, right? If we're doing the work that we're supposed to be doing, how we're talking to ourselves about our circumstances and experiences should be shifting as well. And so I've heard a lot of people who engage in, maintenance ketamine, maybe they come in quarterly for a one-off treatment, that they feel like that word reset is used very commonly. That like they feel like it just gets them back in contact with, this state that they found so beneficial, and sort of control all deletes it in a sense.
I like that.
Well,
and that brings up another point. I've heard a lot of responders kind of mulling around pursuing ketamine-assisted therapy. One of the first concerns I hear is, am I going to become addicted? Another is this going to have a negative impact? And you mentioned it on my career. Am I going to lose my security clearance? Am I going to lose my job? Is this illegal? This is a controlled substance. What do you have to say around all of those fears? And is addiction a risk in this setting?
It's not.
Okay.
And the reason why is because A, we are microdosing, right? We're not using these large recreational doses. B, it's a very controlled setting. C, this is not our only means of combating these symptoms, right? We are not relying on ketamine infusion as a form of monotherapy for a patient, right? This is a piece of their overall work, right? And doing this work over a short period of time, ideally within a 2-week span, there's very little chance of experiencing that. Addiction takes place when you're utilizing a controlled substance day after day, and now your body has accustomed itself to seeing that and is waiting for it, right? And so doing it over a short span of time and having, doing this only 3 days out of the week, your body does not have the opportunity to form that sort of dependent relationship with it. And this is why we don't do ketamine every other day permanently on patients, right? Like nobody wants to even flirt with that. We want to engage this power tool and build something out of it and then back off and do the work,
Great. And I love how you described it earlier, that it creates the space for the work to happen.
Yep.
And,
Yeah.
So what would you say, and have you experienced clients who push back with, I'm afraid that I'm going to lose my clearance, I'm afraid I'm going to lose my job, is this legal? Have you experienced that concern from patients, and how do you address it?
Yeah, how do you address it with your patients?
Full on. Right? I mean, you have to
Contact.
address it. You have to address it, right? They have to do a lot of research into their context.
Yep.
They have to be an active participant in really understanding the protocol. Are they getting polygraphed? What's the fine print, the policy and procedures? It just really depends.
Okay.
And I think we have to be cautious and courageous in regards to new interventions or more intervention, especially with the advent of psychedelic intervention in general and how it's trending in a direction. Right? There's going to be people have to be wise. They got to be smart about their job, the context, and what they're doing. And the policy holders need to get on board with adjusting to these new interventions and really looking at the data and not engaging in witch hunts so readily. Witch hunts are alive and well. And so it takes cautious cautiousness and courage on all the different parts, not just the responder, not just the warrior, but on the policyholders to take a good look at this.
Okay.
Yeah, I think that's an important aspect, is that, understanding what your department's policy is on these things is vital, right? What we're really hoping to accomplish through the types of work that we're doing is really shifting that paradigm so that there's a deeper sense of education across the board, that this is not
Right.
an addictive substance, that this might very well be one of the most potent things that we have available to keep your person working in their department, right? As opposed to this is staying in their system long into the next day, which it doesn't. These things have short half-lives, right?
What's the half-life ketamine?
So half-life of ketamine is like hours, I think, 2 hours, 3 hours, right around there. Like this thing it's gone, it's out of your system, right? So somebody going back onto the job the next day, they are not being influenced by this,
Okay.
right? So there's these, I think a lot of the issues around this is that there's a lack of education,
Yep.
right? And that's the biggest danger, because when people have false assumptions about something that is, really potentially, beautiful, beneficial, and can keep somebody in their boots doing their job day to day, we want to make sure that people know the right information about it, right? There's so much misinformation.
Yeah, and when they stay in their boots and they're getting the job done, like, what effect does that have on post-traumatic growth and transcending trauma, right? It's like, then they got to show up and not be named broken, right?
Love
Then
that.
they got to complete the job, the mission, and not be named broken.
Yeah.
Well, and I think that's one of the ways organizations have really failed responders in the past is if I were on the fire ground and I broke my leg, I'd get put in an ambulance, I'd get treated well, I'd go to surgery, I'd go to rehab, I'd get limited duty or light duty while I was coming back so I don't lose my sense of identity, I don't feel weak, I don't feel like I'm not contributing anymore. But if somebody says in the past, I have anxiety or I have depression, they're treated oftentimes like an outcast. Oh, you're weak, you might be contagious. We don't move them off duty, we don't put them in a role where they can still contribute and have that sense of accomplishment, meaning, and purpose. And inadvertently, I think organizations, out of fear and misunderstanding or lack of information, have not only increased the stigma, but really increased the personal injury.
Yeah.
Yeah, it's
you're-
so funny too, and it's for departments not to see and appreciate the effort and aim of the individual seeking care is so silly. I mean, look left and right. Like for them to be treating this individual who is trying to strengthen themselves as if they are a liability because of depression, anxiety, trauma history, whatever it is so silly, because
Right.
the likelihood that they have experienced that in waves or at different parts of their life is so insanely high these days that it's like, show me somebody who hasn't dealt with this, right?
Right.
This person has the intestinal fortitude to name it and to say, I want to be doing things differently so that I can keep doing this, right? And so the response of penalizing somebody by, calling their security clearance into question and stuff like this is just, it does not make sense to me. It's really, this person is trying to optimize their performance and show up. And you were talking about how this really strengthens the individual. Let's talk about how it strengthens everybody that this individual is helping on a day-to-day
Yeah,
basis, right? Like,
Exactly.
let's talk about the quality of their interactions. When they perform high, everybody that they interact with is touched by that on some level, right? Everything they put their hands to is affected by the performance that they've committed themselves to. So I think that, being able to educate various people as to the safety, the profile, how this stuff can be done productively is going to go a long way over time, and these various agencies and departments understanding, like, okay, I would way rather have this person go through a short period of treatment and come back stronger than before than to lose this person entirely or med board them out. I mean, it's just
Right.
like it doesn't make any sense to me to
Yeah, and the hope
treat them.
that gives.
Yeah.
To see someone overcome adversity, that's infectious.
Oh, yeah.
But we call these things invisible wounds, and it's
Exactly.
like, we don't believe in magic, but like, it's invisible. We'll just act like it's not there, and like, maybe it will go away. It's like
Yep.
what's the stats? 1 in 3 people suffer.
It's getting close to that, yeah.
I mean, it's
Yeah,
like,
pre-pandemic, it was 1 in 5 people
yeah,
suffered
that's
with, but that was
Now it's 1 in 4.
pre-pandemic. Yeah, it's
Yeah.
got to be a lot closer to 1 in 3, and we're talking about how this impacts their ability to do their job on the day-to-day, but think about their families who sacrifice and worry about them, watching their loved one significantly stronger, going out to work with that renewed commitment to what they're doing, having them come back and stay engaged with their families. Like, who would not want that?
Yeah.
Absolutely.
And you can feel our excitement about this, right?
Yeah, absolutely.
You know what I mean? It's
and your knowledge.
trauma.
I'm not passionate about this at all.
Trauma sucks, right? And we're so afraid of trauma. It's like, well, I think maybe we need to shift and be more afraid of not transcending trauma. Because when as a parent, so I've had 9 joint surgeries and 1 spine surgery, and sports related and motorcycle crashes, and I know that my kids now get to see that I went through hell, and they see that I kept walking and I got through it.
Love that.
Like, it's not just avoiding trauma. Like, it's non-resilient. Like, we want to be able to say, yes, this happens, and there's a way to go through it, and that teaches a kid. Like, that's when resilience becomes a multi-generational, experience.
Absolutely.
And we should be fostering that more, and not running away from it because it's like this bad thing.
Yeah, leaving that legacy on our family
Yeah,
members as opposed
love
to, our family watching us find the bottom of a bottle, but saying, I need this help, I can't think my way through this, I'm going to reach out, like that becomes the norm, right? And who doesn't want to leave, that kind of a legacy with their children? This is how you handle adversity, son or daughter.
Yeah, you go into it.
Yep.
Well, and I never heard that concept of multi-generational resiliency, but the data's
I didn't
out
either.
there.
I just made it up.
Good
Isn't that
job. I love that. I knew there was a reason you were here.
He's always doing that.
Well, but the research is out there that if a parent commits suicide, then their child is 50% more likely to
Right.
take their own life, and that's the generational legacy as opposed to resiliency.
Yeah, think about that. This person that's supposed to role model for them chose this as a response. Does that
Modeled it.
Yeah, it's automatically normalized.
Because copycat syndrome is real,
Yep.
and it happens in the negative,
Yeah.
right? And it's powerful in the negative because we have this biological propensity to have a negative bias, and that's biological, right? Like, it makes good sense to pay more attention to bad things than good things because our whole nervous system has one job,
Keep
which
us
is survival, right? So we want to look out for the bad things because bad things kill us. And so, when you combine these things like negative bias, role modeling and or copycat syndrome, it's like we better be paying attention about how we affect each other.
When all of these are stacking, so I love the way you have resource stacking as a counterpoint to that. And so you've talked a little bit about, we've talked about barriers to utilizing psychedelic-assisted therapy. Are there risks to it? And is it for everybody?
Well, definitely not for everybody,
Okay.
right? And everything has its risks, right? I think that there's nothing that you can ingest from the medical community that doesn't have some risks, right? But you work hard to explain those risks with patients and mitigate them, right? The most common risks with ketamine is transient hypertension. So the blood pressure goes up while the infusion is taking place. Is this an issue? No, not generally. We can manage that with an as-needed medication where if the blood pressure, goes above a certain number, we can treat during session, and I actually order those medications ahead of time. The other one is nausea, right? So teaching our patients, hey, listen, don't eat anything 4 hours or so before your treatment, right?
Okay.
And I'm ordering you this Zofran that you can have during treatment if you start feeling nauseated. But, that's another thing that's beautiful about IV infusion is you can control the pace of that, right? So we can
Right.
mitigate in a lot of different ways. So risks oftentimes are part of this discussion is, here are the side effects that you can experience. We know what to watch out for. We're watching you the whole time.
Okay.
I think that's another difference between the way that we do this and other places. The provider is going to come back and check on you every 15 minutes or so to take a set of vital signs. Like, that's not good enough.
Right.
That's not good enough. Like, what if this person is having an adverse response and needs to wait 15 minutes because you just walked out the door?
Right.
But they're in a state that they can't even vocalize, right? Like, so that's, being able to do this stuff the right way is essential at, to mitigating any risks. There are certain medical conditions that would preclude somebody from getting ketamine, which would be uncontrolled hypertension. This person's blood pressure is off the charts and nobody's been able to get it under control, whether with diet, exercise, or medications. I'm going to be less inclined to put that person in a position to have that transient high blood pressure. But also closed angle glaucoma, right?
Okay.
If there are issues with the small vessels, why am I going to put my patient at risk, right? So
Okay.
there's really very few patients for whom this is not an option. From a psychiatric diagnosis standpoint, like a primary thought disorder like a schizophrenia or a schizoaffective disorder, delusional disorder, acute mania, right?
Okay.
Somebody who is acutely experiencing mania, this is not going to be a great idea, right?
Right.
Like this is not what we're going
Not
for.
advisable.
Yeah. There's so many other things to do that, like, let's lean into that work, right?
Okay.
So I think, while it's a small percentage of people who, I can think on one hand in the last year the number of patients I've had to say, like, this isn't for you, right? This is and don't worry about that, right? Because
Right.
these things are, right? And so we'll lean into that stuff. But yeah, that's how we handle that.
Great. Well, and I think a lot of people are curious. What does a treatment look like? What does a treatment protocol look like? You spoke to the half-life and the duration of ketamine in the system, but what does the treatment look like in its own?
Yeah, excellent question. So once the patient comes in for their treatment, our RN who is providing the ketamine treatments, who's an amazing 10-year ICU nurse and just knows her way around this space so well, she's starting an IV line on the patient. Once we've already gotten their vital signs, we know how everything's looking. And she combines the appropriate dose that I've ordered. Typically, we'll start off with a 0.5 milligram per kilogram of the patient's body weight, and that is mixed in a saline bag. And then the infusion begins, right? And the patient is comfortable in our reclining, leather chair and has access to a weighted blanket, and we can really do a lot of ambient work that's curated towards, like we were discussing earlier, creating that biological sense of safety so that the person has the opportunity to let themselves really go into the treatment. But they typically last 60 to 90 minutes.
Okay.
We block off a couple of hours just to give somebody time to kind of come back to themselves fully. We really do encourage our patients, while they are coming back to themselves, let's start writing. Let's start behaviorally activating. Let's start thinking about how we can capitalize on what you just experienced. We're working with, as I said earlier, their ride to make sure that they have a ride home. Some people will need to Uber if they don't have anybody that can bring them, but we're making sure that they are fully back to themselves and fully oriented, feeling like they can, press forward. But we'll do this in these treatment series for ketamine. We do, based on the literature, we'll do 6 treatments.
Okay.
And we'll do those as close to a 2-week span as possible to really optimize the effect of the treatment itself. I tell my patients, like we were talking about, traversing that path forward and backward, that becomes a concrete tunnel after a while, right? And so, like, after that, 5th and 6th session, when you have your sense of, like, okay, I know what's going to happen, I know how to use this and apply it, I mean, it's really fracturing that concrete and bringing it down so you can walk other paths. But that's typically how we'll do it. So 6 treatments in series over 2 weeks' time, 60 to 90 minutes, and then all of the preparatory coaching and aftercare that we've discussed. And sometimes people will come back, as I was saying earlier, for maintenance, whatever. I have a combat vet who comes back monthly, and this is one of the things that really keeps him dialed in with his family, right? And then I have other people who never come back again, right? So, they feel like they did enough work with this, that they got what they needed out of it. So there's really a broad range in how people either engage in single series or engage in maintenance.
Fantastic. So it's very individualized.
Yes.
Okay.
All care should be individualized.
Okay, good point.
Right?
Fantastic point.
This is what's not happening in mental health care, right?
True.
And I think this is why patients hate going to see a psychiatrist, because it's, they're not listening. They are not doing the detective work that they need to figure out where things are coming from. And it is so not it's the antithesis of tailored care.
Right.
So that's one of the things that is really important when we are putting this together. We're having conversations and trying to figure out what this person's needs are.
Okay.
How do we get this person where they're trying to go?
Right. Well, and you had mentioned earlier that sometimes ketamine's not the suggested therapy. I know you mentioned TMS earlier.
Yeah.
How does that work?
Yeah, TMS is so cool, and like this, you're gonna get me on a topic that I could do, like you were saying. How long do we have here? Right, I geek out over this stuff because I really do. My first love was neurology, and functional neuroanatomy is so exciting. And as we learn more and more, we appreciate just exactly how these modes of therapy are a completely different approach to what we're doing on a day-to-day basis. But transcranial magnetic stimulation is the utilization of sort of a small version, if you will, of like an MRI coil, right? Does anything touch you when you go in for an MRI scan? No. And neither does it in TMS, right? It's housed within a plastic helmet that sits over your head, but the electrical current that's being sent through the coil that's housed in that helmet is very specifically shaped, and it creates an electromagnetic field that stimulates functional neuroanatomy. And so when we have been depressed or anxious or having this trauma history, et cetera, there's a lot of different applications for TMS. It affects our functional neuroanatomy. Certain structures start performing in an underwhelming way, right? And I think that when the brain is not functioning the way that it can, it does require more stimulation with medications, right? So one of the excellent properties that TMS has is that oftentimes we are able to sort of back off doses of medications that patients are on, and in some cases stop some medications altogether through that work. But it's a longer time commitment, right? We do this 5 days a week over 7 weeks. Yeah. And that's the reaction I get.
Now we're gonna get on that reaction.
Yeah, right? Whoa, are you serious? And I tell them yeah, that's a commitment, right? But if you're gonna go lean into something and spend some time with it, right? You can have everything in life. You can have the job, the spouse, the house, the car, you name it. Fill in the blank. Your physical health. If you don't have your mental health, you can't enjoy any of it.
Right.
And it speaks to that treachery, right? Like, how many days a week are you suffering, and for how many weeks?
Right, exactly.
Love that.
Like, this is what the mind does.
Math
it's
is
like,
simple.
whoa, 7 weeks. It's like I've only been suffering for like 4 decades. And so it's like we want to challenge that stuff, and that I love that you responded that way, because it's like that's normal, right? It's like this is really, we have to be all in if we want to get better.
Yeah.
Right.
Right? I mean, at whatever level the intervention is, it's full contact. We got to be all in.
Man, and think
Love
about
that.
the things people spend money on to
Good point.
to
Right.
feel better.
Yes.
Like, oh my goodness, right? Like the sort of shop therapy, the vacations, the this and that they spend money on, thinking that it will make them feel better, or that it will sort of bathe the pain or the sorrow. And man, people go all in financially for that.
I don't even bat an eye or think about it.
And it doesn't take them anywhere from A to B.
Wow.
If not for more than a day or two, right?
Yeah.
So I think that, having these conversations with patients and saying, right, like, we want patients showing up who are like, yeah, no, I'm ready to work, right? Because we can't fix people. We don't want to fix people. We want to strengthen them and teach them how to fish. Instead of coming back all the time for their fish, right? Like,
Love that.
I want to teach my patients, we want to teach our patients how not to need us, right? Like, let's get into that work, but somebody needs to be ready to come in and do the work, because I'm telling you, when you apply these power tools, particularly when you do TMS and ketamine in combination, the results are insane.
Wow, that's super cool.
It's the most gratifying thing to watch. And it's my favorite time to say I told you so.
I love that. That's great. So is TMS more indicated for anxiety, or can it be used for a variety?
The cool thing about the company that we work with, Brainsway, is in a category of their own. There's a lot of different companies that make TMS machines.
Okay.
But Brainsway is the only company in the entire market that does deep TMS. So because of the strength and structure of their coil, they can reach 3.5 times deeper than the standard TMS machine can. And when you can reach subcortical structures, you really open up the array of issues that you can treat, right? We can get a lot more specific with the areas that we're going after. And, so they make more helmets than just the one coil, right? So they've got tons of them. I mean, probably 17 helmets, who knows? I mean, they just, they're always doing their work and their research. That's the other thing that I really enjoy about working with them is it's so empirical.
Okay.
It's so research driven. But yeah, so I mean, no, it's not just anxiety. It's anxiety, depression, OCD, PTSD, right? There's even protocols written for cognitive enhancement, for ADHD, for MS, for autism symptoms. Like there's just such a broad application with something like this. And when we talk about the durability of the effect, that's the most impressive thing to me, right? We talk about the effects of doing a ketamine series lasting between a month to 2, in terms of the actual, the effect of the treatment itself. That's why it's so important to do really great work around it, capitalizing on that. But the durability of a series of TMS is, like they've done studies looking at, 6 months, 12 months, 24 months post-completion, right? And over half of their patients are still in remission of symptoms 2 years later, right? What else do we have that does that?
And you've been working with BrainsWave since you had Aurora, right?
Since before, since in residency training, back in Florida, I trained with this.
What year were you in residency again?
Well, I was 2015 to 2019.
Yeah, so he's been working with BrainsWave for a long time.
Long time.
Yeah.
Yep, and so like understanding how this works, how it's applied, how to optimize those treatment protocols that they've developed is really key because it's, there's an art and a science of medicine, right?
Right,
and
exactly.
So, being able to optimize the way that my tech performs those day-to-day treatments and engages those brain areas that we're trying to treat so that we can optimize the outcome is really important too. So it's just the work around this is so much fun. And, but we talk about 80% response rates for ketamine for depression. We talk about, 72 to 76% response and remission rates here for depression. When you combine TMS and ketamine, it's insane. I have yet to see somebody not do extremely well.
That's incredible.
But there are whatever stats around that, but I don't know that there's any study specific to doing ketamine and BrainsWave deep TMS. But I'll tell you, in practice, it's better than 90%.
Wow.
And this has been a field plagued with, ineffective treatments for decades, right?
Yes.
And so when you see that as a provider, if the literature wasn't enough to verify its safety and efficacy, seeing my patients' faces and watching them find themselves is that's enough right there.
It's clear you're both very passionate and so knowledgeable about this. I love the way that you're really relying on the empirical evidence and enhancing it with your clients' responses, their testimonials, the looks on their faces.
That's the best.
That's fantastic. Well, is there anything else that you would want responders to know about ketamine-assisted therapy, about TMS, healing, recovery? You've been so eloquent about a wide array of aspects.
I would say that we here at Mind Spa and many people who understand this demographic, your work is hard, and that is putting it so lightly. And it is it's a heavy mission, and we want to make sure that you remain committed to doing it in the healthiest way possible, so that when you're showing up to everything at your best, and everybody that you're interacting with is benefiting from that. So, don't be mistaken that your friends and colleagues in the profession are not dealing with these issues too, right? Like people,
absolutely.
People put up any number of facades to make it look like they've got it all put together, but I'll tell you right now, on the inside, everyone is dealing with the heaviness from that line of work, and that's the beauty and courage in what they get up and go and do every single day. So, don't just continue to suffer with that. Suffer well, get stronger, and dive into work that's going to make you really love and sustain your career in the ways that everyone who does this line of work is hoping to see.
Love that.
Yeah, I mean, we don't know what we don't know, right? We get into a field and we think one thing, and then the field shows us something very different, and it wears on us. And like, what's us? Well, it wears on our mind, our brain, our body, and our nervous system, and it keeps wearing on us. It keeps being reinforced.
Our families,
And then their nervous systems,
Right.
bodies, minds, get affected. And so, we're so appreciative of the people that got into it for whatever reason. And we have a heartfelt interest that you may not have known what you were getting into. And, we want to just provide some space, we've said, some light, like, let's just keep trying, to get you to perform, the way that you want. I mean, most people aren't going to get out of it. They might show up to work every day and wish they could get out of it, but it's just like, it's like reality, right? There's pensions, there's life, and people say, I can't take it one more time, and then that happens within 48 hours, and you're like, and we have to keep going, and so we just have to keep trying together.
Right.
And being able to have providers encourage you, and having the will to correct providers and say, like, hey, like, that's not how I see it. It's like, okay, cool, like, let's see it how you see it, and let's see what type of intervention we can come up with, but we got to keep trying.
Okay.
yeah.
I hope people can keep trying, because it's a hard job, and it's often thankless. And oftentimes the people we work with, so many of them can't even, because of their clearance, they can't even tell their families
Right.
about what's going on, let alone would they want to, even if they could, because it's like the worst,
Right.
things that they have to see. And it's just like, well, there's even ways around that, where we can process things like that without talking about it. And that's where that whole the evolution of talk therapy, cognitive therapy, and somatic therapies can really kind of get artistic, is so we can process it without talking about it. But like, we got to keep trying.
Yep.
We got to keep trying because they keep trying.
Yep.
Right. I mean,
Yeah, and let's keep it real too. I think that it's important to be receiving care from people who do understand your demographic.
Yes.
Right? And people who understand that we are not better than you because we know what we know. You know your job, we know our job, right? And we're ultimately, at the end of the day, just two adults sitting down and working on this human condition that we're all constantly bumping into all day. So, I think it's important to make connection with people who are also real.
yeah.
Absolutely. Well, and I'm struck by the cultural competency here. I mean, you're both obviously not only very well informed with the science and with the application of it, but you do understand the populations that you're targeting, the military, the veterans, the responders, and it's really refreshing to see, because I think that allows you to establish the rapport that contributes to that sense of safety and security.
Yeah, it makes a
I mean,
big difference.
We're trying to suffer well too.
Yeah.
Well, just being so open about this is the human condition. It doesn't matter if you have a doctorate. It doesn't matter if you're an EMT, a firefighter, a cop.
Yeah, that's important. None of us is immune. I don't care
Right.
what you are.
Death doesn't care at all
Yep.
how you're degreed.
Yeah.
Not at all.
Yep.
And that's kind of one of the main factors of trauma, is death is present and randomness is present, the feeling that we don't have control. Like, our nervous systems have severe allergies to random events that we don't have control over that involve death. Like, our nervous system's like, let's find any creative way we can to stay as far away from that as possible, right? And we can't get away from it, right? Like, we got to get into it.
Wow.
We need to let death become an advisor in a way, so we can grow through it, and look at life a little different.
Yeah, because pain, death, even trauma, these things are not the enemy, right?
It's part of life.
They are part of life, and while they can really wreak a lot of havoc, learning how to manage that well so that you continue to grow personally and continue to see the success you deserve is everything.
Love that.